75-year male Caucasian with a personal history of an hepatitis C virus-related chronic hepatitis. In October 2011, during the hepatic follow-up, the patient, at ultrasound, had a focal cystic lesion of the pancreatic head. Upon EUS, multiple focal cystic lesions were found, one in the neck with septa, one in the tail, and a mild dilation of the pancreatic tail duct. Cytology revealed an IPMN. MRI confirmed the presence of a septated cystic lesion of the neck of the pancreas, which was communicating with the pancreatic duct, and also other cystic lesions of the pancreatic tail. From December 2011 to December 2013, the patient was followed up every 6 months with EUS, without any biopsies. In December 2013, multiple cystic lesions were found upon EUS. The major cyst, of 28 millimeters in diameter, was in the neck of the pancreas. Another cystic lesion in the tail was of 27 millimeters in diameter. And there was also a 6 millimeter dilation of the pancreatic duct. In March 2014, the patient underwent MRCP. The exam revealed a dilation of the pancreatic duct of the tail in communication with a known lobulated cystic lesion. Other cystic lesions were confirmed in the neck of the pancreas. The other small cystic lesions were invariated. The patient is today scheduled for an EUS with fine needle aspiration and confocal endomicroscopy, which will be performed by Dietrich and Giovannini.
We are here at the level of the head of the pancreas. Here, if you see you have where is the pointer? You have the portal vein here. This is one of the cysts, and you have probably the pancreatic duct just here, I think, and you will see the communication probably at this level here. You have the communication with this cyst here. I think just here, yes. And at this level, you see that there is no, the wall of this cyst is thin. There is no, again, the pancreatic duct. Where is the pointer? Again, the pancreatic duct here. You see. I think, I know what I show you, it's the bile duct probably. Then this is the pancreatic duct, sorry. With the cyst here. There is a second cyst here. A third cyst, probably with something inside here. I don't know what is. It's probably plug of mucus inside here. This is the cyst in the cystic. This is the pancreatic duct. You see there is a kind of small stenosis and a dilation just here. This is also there's another cyst with a plug of mucus. There is something here.
Neoplasia.
Or nodule. Yes.
What is the explanation of that really common bile duct? This is really amazing.
No, I don't know what is it. Or it's a dilated. I don't know. It's a cyst. No, it's a duct. It's a duct. I think it's a duct. It's probably the Santorini duct. You see, because probably this is the accessory papilla, because I'm into the duodenum here. Mm-hmm. You see, here?
That's very nicely displayed.
Yes, this is the Santorini dilated, I think.
May I challenge a little bit? Yes. We have IPMN, which is cytologically proven. We have such a lesion in the head and a pretty young patient, and we cannot exclude malignant transformation by whatever modality. So if we have no contraindication, isn't that an indication for operation?
For surgery, yeah. Even because I'm a little bit suspicious here, you see.
And there are some nodules, and such nodules are always indicative for neoplasia.
I'm a little bit anxious at this level. You see, you have a dilation and... I'm sorry, this doesn't work with this. Here, I'm a little bit... you have a dilation of the main pancreatic duct. Where is the... Here. You see this here. This is the Santorini. This is the main pancreatic duct. Here you have
Santorini.
Santorini, yes. And this is the main pancreatic duct.
And nodules within
And nodules,
the Santorini.
yes. Now I will go at the level of the tail to see the body and the tail of the pancreas. Again, here the cystic lesion with the pancreatic duct here. Now I do a clockwise rotation. I follow my pancreatic duct here. Here there is another cyst with here a nodule. This is a nodule, yes. Can increase, yes. This is a nodule, yes. Here, yes. Maybe this could be a good, the good area for the confocal microscopy. I finished my examination. There is another big lesion here. The problem is how to stop the pancreatectomy if we decide to operate this patient. Huh?
It's a multiloculated,
Yes.
the whole organ involving.
And here you have a big
Are you
one.
suggesting a total
Yes.
pancreatectomy, Professor Dietrich?
Yeah, if we, if we think from a theoretical point of view, we have nodules with a proven IPMN, a young guy, even seeing
this,
more nodules
here
right now.
Here you have a
so
nodule
this is an
here.
indication for
Yes.
total pancreatectomy.
Yes, with a reinjection of the ILO of Langerhans of islet to prevent the diabetes. Here you have an nice image of here. Yes.
Here we have to see if that is a mucus or a solid structure.
Yes.
Why not doing contrast ultrasound on
You
that?
can do the contrast. We can do also the confocal inside this cyst.
One is more invasive than the other one.
Yes, we should aspirate, and because this cyst is in relation with the main pancreatic duct. You see,
and this is an important one
yes,
for prognosis.
yeah. We can do both here. Okay, please proceed to the sonoview if you want. I take the sonoview first. And after I will do we will come back. I will do the confocal microscopy in this cyst. But here is different than for adenocarcinoma. If we have enhancement, is a good sign for a tissue. Huh?
So we will look finally to this structure right on here, if there is enhancement, yes or no. If there is enhancement, then there is no doubt about that this is neoplastic tissue. And for me, it would be, how to say, the
course.
final decision to go for surgery. If there is no comorbidity, important comorbidity, if the individual situation of the patient fits into such a decision. But this is a very nice, how to say, example on.
Okay, you can inject the sonoview.
They are preparing.
Can you just tell us how much you're giving, please?
The full dosage in such circumstances.
8 milliliters. Full dose.
4.8.
4.8.
So the full the complete vial under such circumstances, we need a yes and no response. So
okay, go.
That's really the big issue.
Okay, we go. Inject.
But tell us when you inject, because we'll go for the video and.
Inject. They injected. Start the video. Start the video.
Okay, very nice. So let's see. Partially mucus in the upper part. Here, this is mucus.
Now it seems mucus, no?
So most of the structure which we can see is mucus. In the very early phase, we saw some bubbles in the tissue around here. So we have a partially mucus and partially neoplastic lesion in that regard.
I think I will do the, if you I will do the confocal microscopy on this in
Okay,
this
that's
lesion.
excellent.
We are in place with the needle. Now I will pass inside the cystic lesion with and I will push and the needle, the probe. I don't know if you see the probe here. Now I target you have some vessels here. You see, this is, and you see that there is some papilla. We saw some papilla. I will show you after. Now I move the probe at the level of the suspected area here. And the image are not very good, but we try to find the best because as you know yes, we are. This is the normal wall with some vessels. Now I try to move here we have the typical aspect of IPMN with the papilla. You can show again. No. Now yes. Again. Up slowly. Here you no slowly go. Yes, here you have the mucus and the papilla, the papilla aspect with this so-called the finger-like projection, which is typical of IPMN. But there is no sign of malignancy. Again. No. Yes. Yes. I will
Mark,
try to
Mark,
find.
Mark, just to
Yes.
repeat to you, can I ask you again?
Yeah.
Could you please bring these videos with you? Yeah, and then because a lot of people in the audience
yes,
have
of
asked
course.
me
Of
to
course.
ask you to do it tomorrow, please.
Yes,
Thank
I will show you tomorrow. But this is a typical aspect of, we have a typical aspect of IPMN. But you see the vessels here are strictly normal. There is no sign of malignancy. You see I target the area of Dietrich now, and this is tissue, is not the mucus. You have the lower part, you are fully agree. And if I go at the upper part of the tissue here, we have a more mucus. I'm sorry. And you see I move the mucus. You see, with my needle, and this is more mucus than tissue. Again, I will try to change the position, and here you have yes, nice image of IPMN with this finger-like projection, but there is no sign of malignancy. Here I will change. Here you see now.
Play one more time, please. So I will make a video.
Yes.
Very nice. The playing sign.
Yes, you see
And this is a playing ground.
Yes. Okay, now I will try to change the position again. Here, now, come back to this image. Come back. We have a typical image. Here. This is typical of IPMN. Here, this is the intestinal type of IPMN. You see, you have this perfect. This is the perfect image of intestinal type of IPMN. I think there is a very regular. There is no sign of malignancy. I think I agree also with Christophe that there is an indication of surgery in this patient because the lesion there is a lesion of the main duct, and this is an indication. Now I will I target another area. Play. Play. Okay. Now I will target another area. But my probe is into the needle. Okay. And again, here you have the same image. They record this image. This is typical of IPMN with this papilla aspect. And you have some normal aspect with the normal wall of the pancreatic duct in the lower part of the image with this small vessel. This is the normal aspect of the pancreatic duct, and you have the papilla in the right part. which is this is quite this is typical of intestinal type of IPMN. Here you see it's a very nice
Mark,
image.
I think
Okay.
this concept of intercystic microscopy is really fascinating.
Yes,
Of course, we have to learn more from you about the interpretation.
Yeah. You
But
have
as a concept, it's really it's fantastic.
Okay, now I will proceed. I will remove the advantage of this technique. You can remove. I'll show you the probe easily. And now, if you can give me the syringe, I will aspirate the fluid to obtain. No. With the vacuum, I will aspirate some fluid for the cytology, the CE level, and amylase, if you want. But you see, with this technique don't replace the aspiration, because you can do both with the same needle. Okay, here you see the fluid coming into the and the cyst has disappeared. Now I will try to obtain some cells from the wall with this technique of moving the elevator. If you you record, sorry.
I recall and
You see,
make
I
some video.
move the elevator. I put my needle close to the wall, and I do this movement to try to obtain some cells inside the cyst. Okay, I think now this procedure is finished, and
Very nice.
we will see.
Is a very easy way to look for the fluid aspirate of cyst, pancreatic cyst, is to look immediately the fresh drop at the microscope, and you can look for the same picture that you have already seen by the confocal endoscopy. This is a papilla that can be easily seen, is a benign lesion, and also without any staining you can also visualize this structure in the fluid immediately at the microscope. Thanks.